Hello and welcome to this channel. My name is Victoria and today we will talk about abnormal placentation. This is part of our series in gynecology, and if you want to see more, feel free to check out our playlist. The normal placenta is around 22 centimeters in diameter and is formed at the place in the uterus where the embryo first implants. This is usually the superior aspect of the placenta or in one of the lateral walls. The placenta provides oxygen and nutrients to the developing fetus while delivering the baby's waste products to the mother's circulation. The baby is connected to the placenta via the umbilical cord, which contains blood vessels to facilitate transport to and from the baby. In some cases, the placenta does not develop normally, either in position, depth, or growth, or size. It is also possible for the placenta to develop normally initially, but then detach from the uterus. In this video, we will go more in depth about those abnormalities, their classification and consequences for the mother and the baby. At first, I will talk about the abnormalities involving the depth of the placenta. So, usually the placenta grows into the endometrium and is limited in its growth by the stratum basalis, so the deepest layer of the endometrium. There is usually a fibrous layer which separates the placenta from the rest of the uterine wall. When the placenta grows just a little bit deeper and partially invades the myometrium, so the layer just below the endometrium, then we call that placenta accreta. Here the chorionic villi go a little bit deeper than they should. This accounts for around 80% of abnormally implanted placentas. The next, a little bit deeper implanted placenta, is called placenta increta. Here the chorionic villi invade the entire myometrium, so it goes just a little bit deeper than the placenta accreta. This accounts for roughly 15% of abnormally implanted placentas. The last type, the deepest one and most severe form, is called placenta percreta. Here the placenta, or better the chorionic villi, invade the entire uterine wall and can even grow into neighboring organs, such as the bladder or the intestines. This can cause severe hemorrhage during and after pregnancy and makes up around 5 to 7% of abnormally implanted placentas. The major issue with a placenta that invades more structures than it should is that after the delivery of the baby, the placenta will usually be delivered by detaching from the uterus. When a placenta invades deeper, this is either not possible or it will cause enormous hemorrhages, which can be a threat to the mother's life. The abnormal depth of the placenta can be diagnosed using an ultrasound device. There, the thinning of the uterine myometrial wall can be observed, and also the placental lacunae, which are the collections of blood between the villi, are irregularly shaped, which makes the placenta look as if it is eaten by moths. It is also observable that the space behind the placenta, so the demarcation between the placenta and the myometrium, is invisible as the placenta grows deeper than it should. In the case of placenta percreta, it can be visualized if adjacent organs are affected, also by the help of an ultrasound. In the next point, I want to talk about the therapeutic measures. In case of a placenta that grows deeper than it should, our goal is to schedule a delivery and use measures to prevent an excessive hemorrhage during the pregnancy due to abruption of the placenta or rupture of some of the excessive vessels. Some of these measures include the avoidance of pelvic examinations and to advise the patient to avoid sexual intercourse. During delivery, there should be active management and observation of the blood loss. Of great importance is to minimize blood loss and ensure the perfusion of vital organs. In some cases, surgical intervention is necessary, as a curettage to remove remaining parts of the placenta after delivery, or in some cases, a cesarean delivery and hysterectomy if the apparent blood loss is critical and indicates incompatibility with the life of the mother. For placenta previa, unfortunately, it's often necessary to do a cesarean delivery and to perform a hysterectomy before the placenta is delivered. The next point I want to talk about is placenta previa. In this condition, the placenta is partially or completely lying over the lowest part of the uterus, the so-called cervix. This leads to problems in the delivery of the baby, as the descending of the baby and the transition through the birth canal would rupture the placenta and cause massive hemorrhage. When the placenta overlies the cervix completely, we call it a complete or a total placenta previa. In some cases, the placenta is not completely covering the cervix. In this case, it is called a partial placenta previa. A placenta that is lying close to the cervix, up to 2 centimeters from the opening of the uterus, is called a marginal placenta previa. The diagnosis of placenta previa is done during the 2nd or 3rd trimester, as with the expansion of the uterus, a placenta usually moves upwards. So an initial placenta previa might resolve by itself if it's discovered during the 1st trimester. In a case of a placenta previa, a cervical examination and a vaginal palpation is absolutely contraindicated, as it might cause rupture and bleeding of the placenta. Risk factors for the development of a placenta previa is previous damage to the endometrium, as for example due to a curettage or after a previous cesarean delivery. The main symptom that mothers experience is a painless vaginal bleeding. A mother with placenta previa is advised to avoid physical exertion, and in some cases a hospital stay and bed rest are necessary. The delivery is usually done by cesarean section, in which enough blood reserves should be available. The delivery is aimed to occur at around 36 weeks gestation. In earlier gestational age, the fetus might be given lung maturating agents to ensure the health and the viability of the baby. The next point I want to talk about is placental abruption. This term describes the premature detachment of the placenta from the myometrium. So usually the placenta is delivered after the baby, but sometimes the placenta detaches from the uterus when the baby still needs the placenta to receive oxygen and nutrients. This can cause a life-threatening situation to the baby, but also the mother, as the placenta is a highly vascularized structure, and its abruption can cause a massive hemorrhage. The placental abruption can be classified according to its symptomatic picture or according to its way of detachment. The clinical classification is divided into 4 classes, which are as follows. Class 0, which is asymptomatic, and this one can be diagnosed by the finding of a blood clot or an indentation in the delivered placenta. After that is class 1, which presents with mild symptoms. This is the most common type. In this class, the mother often experiences a slight tenderness or pain in the uterus. This class is not characterized by changes in the maternal blood pressure, and the fetus does not show signs of distress. The next class is class 2, the moderate stage. Here, there might be uterine contractions, which can be harmful to the developing fetus, as well as signs of fetal distress. The third class is the most severe, but also the rarest class. Here the mother usually develops a state of shock, and the fetus unfortunately often is not able to survive this condition. This stage is also characterized by coagulopathy. The other way of classifying placental abruption is by the presence or absence of visible bleeding. So there's the revealed type, in which the placental abruption can be detected by vaginal bleeding, and there's the concealed type, in which the bleeding is retained in a way that there will be no vaginal bleeding. This often happens when the placenta detaches at the center instead of the margins, so the margins will still be intact and contain the leaking blood. The last point I want to talk about is a placenta that does not develop as one structure, but as several parts. The most common form is a bilobar placenta. Other forms include a trilobular, a tetralobular, or a succenturiate placenta. In those cases, the placenta is not one developing structure, but has an accessory lobe of varying size. In the case of a bilobar placenta, the two parts are approximately equal in size, while in the placenta succenturiate, one of the lobes is significantly smaller. Those accessory lobes are usually connected to the main placenta via blood vessels. The incidence of this condition seems to increase in cases of placental infections and preeclampsia. One theory for the development of a bilobular placenta is also that it might occur if the embryo implants in an area of the uterus in which the blood perfusion is decreased. The risk of a bilobar or succenturiate placenta is that the fetus might be born prematurely or the growth might be impaired due to lack of sufficient blood supply. Other conditions that might arise are polyhydramnios, so too much amniotic fluid, vaginal bleeding, or retaining parts of the placenta within the uterus after delivery. The treating physician should be aware of the multiple parts of the placenta, as after the delivery it's necessary to examine the uterus for remaining parts and remove those if they are there. Those parts might also bear a risk for a potential source of blood loss and so for postpartum hemorrhage. That's all for this video. I hope it was helpful, and if you like our channel, please subscribe. Thank you very much.